Hello, you are most welcome, ladies and gentlemen, to your Power Behind a Voice on Tuesday Night Anatomy with Daniel Okwan. Yes, today's case study, this is how it goes. Following a surgical procedure to remove the parotid gland, that is, of course, in the case of parotidectomy, the patient, yes, has reduction in the saliva produced, of course, in the mouth. Yes, not only that, in the first few weeks after the surgery, yes, when this patient, of course, shifts around the area of the angle of mandible, the skin over here, together, of course, the skin over the parotid gland area, this patient, yes, could not feel anything. Also, when this patient is touched, okay, at the skin of the mid of the lateral two-thirds portion of what we call the upper two-thirds portion of the auricle, yes, this patient, yes, doesn't feel anything. Now, after about 5 months, yes, of course, this patient could, yes, could now produce adequate saliva when food gets in there. But my friends, at the same time, what happens is that this patient experienced some kind of redness, okay, and of course, also sweating around the skin over the angle of mandible and of course the parotid gland area. Now, what is the clinical diagnosis? And my friends, also, what is the anatomical basis for this clinical diagnosis? And my friends, to help answer this is what I want you to know. Now, first of all, remember that this patient underwent surgical removal of the parotid gland. Now, there are so many neurovascular structures which can be injured, but I'm trying to limit this to today's discussion. Some other time, I'll bring in some other things. But as far as the aortic ganglion is concerned, is that ganglion where is supposed to, supply what we call this, parotid gland. And it is doing so through this, what do you call it? This postganglionic nerve, which of course is a branch of what we call the mandibular nerve. Okay, actually the posterior division of mandibular nerve. I am talking about the auriculotemporal nerve, ATN, auriculotemporal nerve. And so one thing is that because this auriculotemporal nerve supplies the parotid gland, yes, during parotid gland surgery, yes, it is likely that it's going to get injured. Not only that, another nerve that is susceptible to getting injured is, of course, that nerve which I described. That, yes, some weeks ago I described that, of course, is related to, of course, it emerges from, of course, the nerve point in the posterior triangle of the neck. Yes, that runs, yes, on the belly, ascends upwards on the belly of what we call the sternocleidomastoid muscle. Yes, that nerve is what we call the great auricular nerve. Because that great auricular nerve, which will supply the skin over the angle of mandible, that of parotid area, of course, as well as the, lobe of the ear. And so, based on this clinical presentation of what the patient not having sensation over these areas, then what it means is that of what the nerve that was injured, first of all, is of course the great auricular nerve, root value C2, C3. Now, not only that, we said also that this patient cannot, of course, give a lot of maximum volume of saliva when eating, and also, yes, there's loss of sensation over the upper lateral aspect of the upper two-thirds portion of the auricle. And so it clearly tells you that, of course, the auriculotemporal nerve, yes, is also injured in that regard. So now the question is, going forward, in no time, in about 5 months or so, what happened was that, yes, this patient can now produce maximum saliva, okay? Then it means that the nerve has been restored. And also, another thing that was accompanied, okay, by restoration of the nerve, auriculotemporal nerve, obviously, is the fact that, yes, whenever food gets in there, yes, you see that kind of sweating over the skin, over the angle of mandible, of course, the parotid area. And so, my friends, clearly, the presentation over here is something that is consistent with something we call Frey's syndrome. Frey's syndrome. F-R-E-Y'(S), Frey's syndrome, someone's name, Frey's syndrome. And so now the question is, what is the anatomical basis for this clinical presentation? Now, after the injury of these nerves, what will happen is that after some time, there's that kind of tendency of regeneration. Now, for whatever reason, yes, the brain can get confused. So that what will happen is that the nerves, which are supposed to regenerate, for instance, the fibers of auriculotemporal nerve, they are supposed to unite, and that's all. That of great auricular nerve, they are supposed to unite in the process of regeneration. By situations where, of course, for instance, if this is great auricular nerve and this is auriculotemporal nerve, there could be that kind of fusion of these nerve fibers. And we are aware that, of course, auriculotemporal nerve is supposed to send secretomotor fibers to, of course, this parotid gland, so that salivation will happen whenever you're taking food. So especially when you're taking spicy food, okay, a lot of salivation taking place, then what will happen is that at the same time, the skin that is supplied by, of course, the great auricular nerve, because the nerve is combined with, of course, auriculotemporal nerve, then what is going to happen is that, yes, at the same time salivation is taking place over here, the fibers of this great auricular nerve will also be stimulated to, of course, innervate this area. And the saliva that is coming over here, you will be seeing manifestation of sweating. Okay, because of course, if you are supplying the skin, then it means that also, yes, the sympathetic fibers over there will also be supplying, of course, the sweat glands also. And that is why when one is eating, there will also be redness and sweating over the skin, over the angle of mandible. That is the anatomical basis of the Frey syndrome. Now, sometimes I get to the classroom and I tell people that, yes, it is not always that, of course, in this case, auriculotemporal nerve will get fused, or get that during the regeneration will get fused with, of course, the great auricular nerve. But this connection, reconnection or regeneration, accidentally, it can happen to that of, what we call the lesser occipital nerve, which we described again the last time when we were looking at the nerves that exit the nerve point at the posterior triangles of the neck, lesser occipital nerve. So in such a case, that Frey syndrome, the clinical manifestation will not be sweating over the skin, over the angle of mandible, because the regeneration happened between, of course, auriculotemporal nerve and lesser occipital nerve. The sweating will be happening over the skin, over what we call that behind out of the ear, okay, the occipital area, this area. Yeah, not only that, it can also, during the regeneration, it can also happen to a branch of the anterior, of what we call a branch from the anterior division of what we call the mandibular nerve by way of the buccal branch, okay, and that guy is, we said, is sensory, although it pierces the vaccinator muscle, doesn't supply it, so there will be that kind of sweating over the skin, okay, over what we call the vaccinator region or the cheek region. Okay, so these are the things that I want you to understand, the anatomical basis of the Frey syndrome. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.